Chapter 21, Neurologic System Introduction. The nervous system is divided into two main parts, your central nervous system and your peripheral nervous system. When we talk about the central nervous system, this is your brain circulation, and your spinal cord. For your peripheral nervous system, this is your autonomic nervous system, which is your sympathetic and your parasympathetic. So let's go over central nervous system first. Let's talk about brain. The brain has structures and parts that's actually responsible for coordinating and regulating some bodily functions. Let's look at this picture in page 347. And in there you can see the structures of the brain. You have your cerebrum, the cerebellum, and the brainstem. Brainstem is your midbrain, your pons, your medulla oblongata, which we will talk about later on, has a very important function. Your cerebellum is responsible for the balance, and cerebrum also will talk about what are the parts and the structures and what are the functions of these structures. So cerebrum, let's focus on cerebrum. When we're talking about the cerebrum, this is actually composed of the right hemisphere and the left hemisphere, and also are subdivided into lobes. If you look at page 348, you are going to see the lobes, the frontal lobe, the parietal lobe, temporal lobe, and the occipital lobe. So what is the function of the cerebrum? It has that complex function. What are they? Recognition of the sensory input, thinking, right? Emotions, also regulating the endocrine and the autonomic function. Okay, and then the cerebrum is divided into two halves, which is like what we said is the right and the left hemisphere. And this is actually connected by what we call the corpus callosum. And while we're talking about the hemisphere, please remember that the right hemisphere is actually responsible for the control of the left side of the body, whereas the left hemisphere is responsible for the opposite side, right? The right side of the body. And this is why if we talk about cerebrovascular accident, the stroke later on in the succeeding chapters, we would know that if there is a stroke that's actually affecting the right side of the brain, then you will actually see the manifestation and the signs and symptoms on the left side of the body. Whereas if the stroke actually is happening on the left side of the brain, then you will see the manifestation on the other side, on the right side of the body. More things to remember when we're talking about the hemisphere. The left hemisphere is actually controlling the mental processes such as your language use, mathematics, and then reasoning powers. And then the right hemisphere actually is the one that's regulating emotions, your emotional and artistic tendencies. Okay, all right, now let's move forward with the lobes of the cerebrum. So you have the parietal lobes, the frontal lobes, the temporal, and the occipital lobes. So look at page 348. Like I said earlier on, you're gonna see there the lobes, right? And then the next picture, the picture in the bottom, you're going to see the areas of function in each of those lobes. Let's go over them. For example, your frontal lobe. You can see that it's actually responsible for the conscious thought, right? And you even have this what we call Broca area, which is a motor speech area. One part of the premotor area is also responsible for the muscle coordination. And then you have the parietal lobe. If you look at it, you're gonna see that it's actually responsible for the somatic sensory, and is responsible for your Wernicke area, which is a sensory speech area. Now, if you look at the temporal lobe, it's responsible for the auditory association area, auditory meaning hearing. And then when you look at the occipital lobe is the one that's responsible for the visual association area and the visual cortex. So seeing, right? Okay. And then don't forget that the thalamus, the hypothalamus, the basal ganglia, which is the one that's responsible for the sleep-wake cycle, is actually important structures in the cerebrum. Okay? The box 21.1 in page 347, I encourage for you to actually read through this and then remember what are the functions of the major parts of the brain, because again, when we talk about disorders later on and what is wrong on those parts of the body or the brain, then you would understand why the manifestation or the signs and symptoms is actually why it is like that, right? Okay, now let's move forward. The cerebellum. Cerebellum is located at the back of the brain. It's kind of like under that occipital lobe of the cerebrum. And this one is responsible for coordinating movement and balance and posture. So if this is the part of the brain or the nervous system that is actually affected, then you would see that your patient is actually going to have some kind of balance problem, right? Okay, let's move forward. The brain stem, like we talked about earlier on, this is composed of the midbrain, the pons, and the medulla oblongata. And this part of the brain is very important. Not that the other parts are not important, but this one is the one that's actually controlling the vital basic function of the body. This is your respiration, your heart rate, and the consciousness. All right. Now we're done with the cerebrum and then the cerebellum and then the brain stem. Now I just want to mention what we call a cerebrospinal fluid, or your CSF. This one, if we recall, is composed of water, glucose, sodium chloride, and protein. And this is produced in the ventricles of the brain and is the one that's actually circulating and acts as a shock absorber for the brain and the spinal cord. Keep in mind that it is produced in the brain, in the ventricles of the brain, in the arachnoid granulations. However, it needs to be reabsorbed in the arachnoid villi, okay? this fluid needs to be reabsorbed in the arachnoid villi. It needs to be a balance. So it gets produced in the ventricles, then it's going to circulate, and then it needs to be reabsorbed. If somewhere along those lines something went wrong, then you're gonna see disorders like your hydrocephalus, for example. And if there's actually excess amount of this fluid in the brain, it really could cause a lot of problem, because we will talk about the intracranial pressure later on, but it will actually cause what we call an increased intracranial pressure, and that will cause a lot of problem in the brain. All right, let's move forward with the brain circulation. Of course, just like any other parts of the body, the brain needs that blood flow, right? That oxygen. Things to remember, the brain actually consumes 20% of the oxygen supply and cardiac circulation in each minute. Two major arteries that's actually responsible for the brain circulation is your carotid arteries and the vertebral arteries. The carotid artery is actually going to be divided into your external and your internal arteries, which the external is actually the one that's supplying the blood to the face, where the internal arteries is actually further divided into um, becoming the cerebral artery, and that's the one that's actually supplying the blood to the brain. The vertebral arteries is the one that actually circulates or gives the brain circulation to the brainstem, and the combination of these internal carotid arteries and the vertebral basilar arteries, they are the ones that actually unite, and it is what we call circle of Willis, if you guys recall from the anatomy and physiology. Okay, we're done with brain circulation. Now let's go over your spinal cord. For the spinal cord, this one extends from the C1, which is your cervical vertebra. This one extends from the cervical vertebra, your C1, to the level of the second lumbar vertebra, which is the L2. They're the ones that are responsible for what we call those afferent, your afferent and your efferent sensory nerves. Also, this is actually when we will remember all about our 12 cranial nerves. If you want to remember those C1 to C7, all of those things, it's actually in page 351, and you're going to see the bony structure of the vertebral column, which is your cervical curve from C1 to C7, and then you have your thoracic, right, cervical, and then thoracic, which is from 1 to 12, and then you have your lumbar, which is 1 to 5, and then your sacrum, which is 5, that's actually fused into 1, and then your coccyx is 4, that is fused into 1. They are all in 351. Also, if you want to see the circle of Willis that we did talk about earlier on, that's actually in page 350. This is where you're going to see the cerebral circulation, and on that middle part right there is the circle of Willis. Okay, peripheral nervous system. This is your autonomic nervous system that we did talk about earlier on. What do they do? Autonomic is involuntary, if you guys recall, right? Autonomic nervous system actually controls the involuntary activities of the muscles, right? Smooth muscles, cardiac muscles, and some glands. Again, you have your sympathetic and your parasympathetic, which is your fight or flight, or your rest to and digest. Sympathetic is your fight or flight. Parasympathetic is your rest and digest. For example, if the body is actually under stress or under a threat, right, it's going to trigger that sympathetic nervous system, which is going to actually have that secretion of the epinephrine and then the norepinephrine, which are neurotransmitters, right? And what it does is it actually increases the heart rate. It actually constricts those peripheral blood vessels because it wants the blood pressure to rise. Then you're gonna have your pupil will be dilated so that the visual field is actually bigger, because again you're getting ready to actually fight or flight. Then you have the parasympathetic nervous system, which is actually the one that is slowing down everything. This one is the one that actually stimulates the rest response. What it does is it decreases the heart rate, it decreases the blood pressure, and then your pupil is actually gonna go back to its normal size, right? Okay, if we want to go over the effects of your sympathetic and your parasympathetic stimulation, you can actually see them in page 351, the table 21.1. I highly recommend for you to actually read this, remember it. It's very helpful. For example, let's talk about uh, the eye, right? For eye, you're gonna see effect of the sympathetic stimulation is actually going to be dilated because again you're getting ready to fight or flight, and then while with the effect of your parasympathetic stimulation is going to be constricted, going back to its normal size, right? And then your heart, for example, heart muscle, effect of the sympathetic nervous system is actually increasing the rate, increasing the force of contractions, and then the effect of the parasympathetic is actually to slow the rate and to decrease the force of the contractions. So very important. This table 21.1, very important. Please read through it, remember it. 351, page 351 and page 352. Okay, going back to the functional unit of the nervous system, this is actually what we call your neuron, which is the nerve cell. If you guys recall your axons and your dendrites, where the axons is actually the one that is conducting the impulse away from the cell body, and the dendrites is the one that actually convey impulses towards the cell body, right? Axons away, dendrites actually towards the cell body. Then if you guys recall, neuron actually connects that impulse from one neuron to another neuron. It's gonna go through a neural synapse, which is the space in between the axons and the dendrites of the next neuron. And in this synapse is actually where those neurotransmitters is being released. Some neurotransmitters that we need to remember, you have your acetylcholine, your epinephrine, and your dopamine. Very important when we're talking about the nervous system. Alright, picture of the neuron or the nerve cell is actually in 353. If you want to see that picture, you can see the axons and the dendrites and the nucleus. Okay, moving forward, what are the age-related changes when we're talking about the nervous system? So here they are. The number of nerve cells, which we just did talk about, your neuron, actually decreases. So remember, these neurons are actually communicating with each other via that impulse, right? So, for example, I'm going to pick up a cup of water. So, in order for me to do that, the neurons from my brain is actually going to send that impulse all the way from my brain going to my hand for the movement to actually happen, for me to actually pick up that cup and actually, if I need to drink it, put it in my mouth, drink the water, and then put it back on the table, and then put my hand down, right? Those are like the neurons that's actually communicating towards each other via the neurotransmitters, your what we call, what we just talked about, your acetylcholine, your dopamine, and all of those neurotransmitters that we did talk about. So if we're talking about the age related changes, and we're saying that, yeah, the number of nerve cells actually decrease. So imagine what is the effect of that in the body. If you have less nerve cells that's actually being stimulated or communicating towards each other for a movement to actually happen, right? That's why it makes sense that when we get older, some of the some of the problem that we actually will see is like slowing down movements, right? Or the coordination of the movement is not actually as smooth as when they were younger, right? Okay, next one, the brain weight is reduced, ventricles will increase in size, lipofuscin, which is an aging pigment, is deposited in nerve cells with amyloid, which is a type of protein. There will be an increased plaques and tangled fibers in nerve tissue. Eye pupil will often be smaller, may respond to light more slowly. The reflexes is intact except for the Achilles tendon jerk, which is often absent, and the reaction time increases, especially complex reactions, which makes sense. Think of the older population. For example, think of throwing a ball and asking an 18-year-old to actually catch it versus ask a, let's say, an 85-year-old um, patient. Um, if you throw a ball at them, you're going to see like a slower reaction, right? Versus the 18-year-old. So the reaction time actually increases as the age actually advances. Tremors in the head, face, and hands are common. Again, this is something to do with the nervous system is actually the one that's controlling and regulating the movement. And then some may even develop dizziness and problems with balance. All right, before we move forward with the types of disorders, let's talk about the cranial nerves first. They are in page 357, table 21.2. Cranial nerves, you have from 1 to 12, and let's go over them one by one. The first one is your olfactory. Cranial nerve number 1 is olfactory, which is responsible for your smell. How do we test it? We ask the patient to close their eyes and then put something in front of their nose and then ask the patient to actually tell you what is it that they're trying to smell. Cranial nerve number 2 is your optic, which is responsible for the vision. How do we test it? We do the 6 fields of gaze, right? Your visual field, you do the visual acuity. Cranial nerve number 3 is your oculomotor, which is the movement of the eye. Medially, upward and inward, downward and outward, upward and outward. Pupillary accommodation and constriction. How do we test it? It's either we do a light examination, which is direct and consensual, or you do that perla, that light accumulation, which is you're gonna shine the light in front of the patient's eye, and then you're gonna see if the pupil is actually going to constrict. Another thing is what we call doll's eyes, which is when we move the head, the eyes is actually going to move in opposite direction. So like for example, you're gonna turn the patient's eye in the the face on the right side, the eye is actually going in the opposite direction, which is the left side, and vice versa. Cranial nerve number four is your trochlear, which is the movement of the eye down and inward. How do we test it? We do what we just talked about, your doll's eyes. Cranial nerve number five is your trigeminal. This one is actually responsible for the facial sensation, chewing, light touch. It branches into your ophthalmic, maxillary, and mandibular. How do we test this? We do the light touch test, which is actually you're going to ask the patient to close their eyes, and you're kind of like going to maybe use a cotton ball and then touch the side of the cheek, and then you're going to ask the patient where do they feel it, or do they even feel the light touch. That's one thing. That's one way to test it. Another way is to actually ask the patient to clench the jaw, and then kind of like check the masseter and the temporalis muscle if it's actually um, responding to the clenched jaw. Cranial nerve number six is your abducens, which is the movement of the eye laterally. How do we test it? We do the doll's eyes. Cranial nerve number seven is your facial, which is your facial expression, or salivation, lacrimation, and the taste. How do we test it? We ask the patient to actually smile, frown, show teeth, puff out the cheeks, and then close their eyes tightly, raise their eyebrows, and then actually ask the patient to taste something in the anterior part of the tongue. Cranial nerve number eight is your acoustic, which is your hearing and your equilibrium. How do we test it? We actually ask the patient to close or cover one of the ear, and then whisper something on the other ear, and then asking the patient to actually tell your what you just told them. Cranial nerve number nine is your glossopharyngeal, which is the motor response for sensory. Um, and then how do we test it? We actually ask the patient to swallow on command, and then you can also elicit gag reflex, and then you ask the patient to actually taste something, but this one is actually in on the posterior part of the tongue. Cranial nerve number 10 is your vagus, which is responsible for the movements of pharynx and larynx. This actually raises the palate and innervates organs of thorax abdomen. How do we test it? We do a gag reflex, and then you're gonna see and take a look at the uvula, right? If it's actually elevating. Cranial nerve number 10 is your spinal accessory, which is the movements of shoulders and neck. What we do is we ask the patient to shrug their shoulders, and turn their head from side to side, and then you're actually going to put a slight resistance. Cranial nerve number 12 is your hypoglossal, which is the movement of the tongue for speech and swallowing. How do you test it? You ask the patient to actually protrude their tongue and then move it from side to side. Right? Okay. Um, Another thing that I highly recommend for you guys to read and remember is this table 21.2. While we're on this page, let's go over the adult neuroflow sheet too. This is a sample of a neurocheck, and you might encounter this when you're taking care of patient that's actually having that neuro disorders or conditions. Page 356. This is the adult neuro flow sheet. So the flow sheet is actually divided into three: your Glasgow Coma Scale, your voluntary motor, both right and left, both upper and lower extremities, and then your cranial nerves, that which we just did talk about. For your Glasgow Coma Scale, you're gonna take a look at that in the right bottom side of the box. You're gonna see it's further divided into three: eyes opening, best motor response, and then the best verbal response. So these are how you're going to score the Glasgow Coma Scale of a patient. You have, for example, you have eyes opening, and you have a patient that's actually just responding to pain. So the score would be 2 based on this scale, right? Look at that, because it's 4 is spontaneously, 3 is to verbal command, 2 is to pain, and then 1 is to no response. And then for best motor response, you're going to check if it's 6, which they obey command, 5 localized pain, 4 flexion to pain withdrawal, 3 flexion decorticate, 2 extension to pain decerebrate, and then 1 is no response to pain. And then you have your best verbal response, which is your 5 to 1, 5 being very oriented, and to 1 with no response. Obviously, with this scale, the higher the score is, that's what you want, right? Because the higher the score is, the more alert and oriented your patient is. Okay, and then let's look at those pupil size key. You have your B, your S, and then your A. B for your brisk, S for sluggish, and A is for absent. What are we talking about here? We're talking about the accommodation and the reaction of the pupil. So, for example, you're actually shining a light in front of the patient's eye, and the pupil actually constricted right away. Then you're gonna say, oh, the pupil size is actually, or the reaction is actually brisk. And then what we want is 3 millimeters, right? That's actually the ideal size of the pupil. Obviously, if it's very small, like your 2 millimeters there, or even something that's smaller than that, then the pupil is constricted. And if it's big or dilated, like your 8 millimeters there, then you're gonna call it that the pupil is actually dilated, right? Okay, obviously also you want to check if the reaction is present or absent. Is it symmetrical or asymmetrical? And what does that mean? It means whatever is happening on the right eye should be happening on the left eye at the same time. For example, you're the nurse that's taking care and assessing a patient that actually just had a motor vehicular accident, and you're doing a neurocheck, neuroflow sheet, and you actually shine a light in front of the right eye, and you see that the pupil is actually constricting, responding to that light that you actually just shine in front of the patient's eye. What you're going to want to see is what's happening on the right eye should be happening on the left eye. Because if it's not, something is wrong, right? Because it's not symmetrical. What you want is symmetrical, okay? All right, next, let's look at this table 21.3, which is a grading scale for muscle strength. So, we did talk about the nervous system is actually responsible for movement and muscle accommodation of muscle strength, right? So when you're assessing someone that has a neural disorder or condition, you're gonna want to actually do this grading scale for their muscle strength. Look at this table, read through it. Score of 0 is when there's no movement or total paralysis. 1 is weak contraction. 2 is muscle moves when supported against gravity. 3 is There's an active muscle movement against gravity, which is what we want, right? Which is what we want. And then 4 is full active range of motion against gravity, but with some weakness when resistance is tested. And 5 is full active range of motion against gravity and resistance. All right, more assessment. Go to page 358, your table 21.4. This is the assessment techniques for major muscle group. So we talked about those C1, 1, 2, 3, 4, 5, 6, 7, and then your thoracic up to 12, lumbar and sacrum and the coccyx earlier on. So this is what we're talking about in the nerve root. Look at page 358, C4 to C5. This is the abduction of the shoulder. How do you assess it? You shrug the shoulder against downward pressure. You're going to ask them to actually shrug their shoulder, and you're putting like a slight pressure. C5 to C6, you're going to ask the patient to actually flex the arm toward the body against a resistance. And then C7 is when you're actually asking the patient to extend the arm away from the body, and then you're putting resistance. C8 is hand grasp. So you're going to ask the patient to grasp the hand of the examiner, or you as the examiner, grasp your hands, your fingers, and then attempts to withdraw fingers from the grasp with the resistance, of course. L2 to L4, you're gonna have them raise the leg against the resistance, and then knee extended away from body against the resistance. And then L5, your foot dorsiflexion. You're gonna ask them to actually pull the foot while upward while you're putting resistance. L5 to S1, there's a knee flex toward against resistance. You're going to ask them to flex that knee toward body, and then you're going to put some resistance. And S1 is foot and toes pointed downward against resistance. So these are the assessment techniques if you're actually trying to assess the nerve roots based on the location. So let's go back to this slide really quick. Types of disorders for your neurologic system. We have developmental and genetics. Developmental disorders is when um, it actually started to happen or started to develop when the person is actually under the development in the embryo, right? Or it's probably genetics by genes when were they inherited from the parents. What are the example? One example is your hydrocephalus. Trauma. This is also very common. For example, you have a patient that just had a motor vehicular accident, hit their head really bad. Now you don't know if there's like, increased intracranial pressure or there's bleeding inside the brain from the trauma itself. And then you have inflammations and infections, right? Your meningitis, encephalitis. Yeah, we'll talk about those disorders later on. Neoplasms, if there's like a brain cancer or cancer somewhere in the neurologic system. Degenerative process. We did talk about the age-related changes earlier on. This one is a degenerative process of the neurologic system where everything else or structures of the neurologic system is actually degenerating. Obviously, if those structures are degenerating, then the function of that specific structure is actually decreasing as well. Vascular disorders, we did talk about those brain circulation earlier on. So if something is actually wrong with the circulation, with the brain circulation, then it causes a disorders. Metabolic and endocrine disorders. Again, in the brain, there's your glands that are actually responsible for the endocrine secretion. So if something's wrong with that, then it actually affects the metabolic and the endocrine disorders. Nursing assessment of neurologic function. So we did talk about those assessments with the cranial nerves and the neurologic flow sheet and the muscle strength, and we even talk about the assessment techniques for the major muscle groups. But first of all, of course, you're going to check the health history of the patient and the reason why they're seeking the care. Are they here because they had an accident? Are they here because they feel like their memory is actually um, getting bad, or there's something wrong with the coordination of their movement? So, what is the reason for seeking care? And then when they do that, you're actually going to assess also the past health history of the patient. What is the norm for this patient now? What is this symptom something new versus the past health history of my patient? What is the norm, right? What is the baseline of my patient? Then that's when you're actually going to do the head to toe assessment and your cranial nerves and all of those muscle groups assessment. Now let's talk about diagnostic tests and procedure. Lumbar puncture. This one is an invasive procedure, and what it does is it actually takes a sample of your CSF, your cerebrospinal fluid, and then so that we can send it to the lab, and then lab can actually check if there's an inflammation or infection that is going on inside the brain or spinal cord. What they do is they will actually position the patient first. Let's look at page 362, your figure 21.11. That is actually how you're going to help the patient to position. They will be in a flex position because what you want is to actually get into or maximize that space between those vertebrae. The needle is actually going to be inserted between L4 and L5 or between L3 and L4. What they want to do is to gain entry to this subarachnoid space um, and collect that CSF fluid. Once that fluid is collected, you're going to get that sample sent to the labs for analysis. Right. What are things to remember? Your normal CSF should have a pressure 50 to 175 millimeters of H2O. Like I said, it's very important to remember pressure, your intracranial pressure, because it's going to create those problem if you have an increased intracranial pressure. But we'll talk about that later on. And then normal pH of your CSF should be 7.30 to 7.40. And what are the characteristics of the CSF? It should be clear, colorless appearance. Okay. And then when they check for the fasting glucose, it should be 40 to 80 milligrams per DL. And white blood cells should be 0 to 5 small lymphocytes per cubic millimeter. Okay, so what are the responsibility of the nurse when the patient is actually going for a lumbar puncture? First off, of course, you're gonna want to witness the or making sure that there is an informed consent. Again, this is an invasive procedure. So you're gonna want to make sure that there is an informed consent. But you're not the one that's getting the consent, right? We remember that as a nurse, we witness the informed consent. It should be the physician that's actually getting the informed consent and explaining everything to the patient. Now, if you have a patient that told you um, oh, I did not understand what what the physician actually just told me. Your responsibility is not to explain the procedure to the patient. Okay, your responsibility is to actually grab that primary doctor or the surgeon or whoever it is that took that consent and bring them back to the room and talk to the patient and make sure that they actually um, explain everything to the patient, that the patient actually understand the benefits and the risk, and they actually have no other questions before they even go and do this procedure. All right, now let's go back to this lumbar puncture. So one of the responsibility is to make sure there's an informed consent, right? Um, Please make sure to have the patient void, because you are going to position that patient in that flex position in page 362. So it's going to be very uncomfortable if they have a full bladder. So make sure that the patient actually voided before the procedure. And then support them to be positioned on that side. That is for prep, right? For post procedure for your lumbar puncture. One of the common risk that the patient actually um, experience after a lumbar puncture is a headache. So, what do we do as nurses after a lumbar puncture? If the patient is actually complaining of a headache, then you're gonna want the patient, or gonna ask the patient to lie flat for a specific period after the procedure. It helps with decreasing the headache. Okay, so make sure that you tell the patient or educate the patient to lie flat, because it helps with the headache. And then you're going to encourage oral fluids. And then, of course, this is an invasive procedure, so you're going to want to assess the patient for any complication, right? You're going to check if there's a CSF leaking in that site. You're going to check if there's a bleeding from the puncture site. You're going to check their vital signs, right? Because if there's any changes in the vital signs, that's when you're going to know that there is something wrong with the patient. What are the what are the other responsibility of the nurses? You're the one that's going to make sure that that specimen that they collected goes to the lab, and then just make sure that that puncture site is actually dry and covered, and the bandage is actually not saturated with CSF or blood. If the patient is actually experiencing severe headaches after a lumbar puncture, there is what we call a blood patch. So what they do is they're going to inject a small amount of the patient's blood into the puncture site, and that blood that they're actually going to inject is going to clot. When the blood actually clots, then it's going to seal that puncture site, and it's helping with the further loss of the CSF, and it's helping with decreasing the headaches. Okay, all right, moving forward. Electroencephalography, your EEG, is used to detect seizure activity, because this one is actually monitoring the electrical activity in the brain. This one is electrical activity in the brain. However, even though this one is actually monitoring the electrical activity in the brain, please make sure that you educate your patient that they are not going to feel any electrical shocks. Okay? The patient is not going to feel any electrical shocks. What they're gonna do is they're gonna put electrodes in the scalp of the patient, and then that's how they're gonna check the electrical activity of the brain. Pre-op or pre-procedure, you as a nurse is going to make sure that the patient actually shampoos the hair before the EEG, cleans their hair before the procedure, withhold the medications, which is your anticonvulsants, your sedatives, your stimulants, and your tranquilizers. Those medications that actually affects the nervous system. So you withhold those medications. Caffeine also. Caffeine needs to be on hold for up to 48 hours before the EEG. Okay, post procedure, you're gonna help the patient to just shampoo the hair to remove those electrode paste. All right, electromyography. What is that? EMG. This one is actually to diagnose neuromuscular abnormalities like your carpal tunnel syndrome, your myasthenia gravis, your ALS, your peripheral neuropathy. What's the responsibility of the nurse? You make sure for preparation for pre-procedure, there's a consent, right? There's a signed consent. No caffeine or smoking for 3 hours before electromyography. Post procedure, make sure that we inject the sites of the needle electrode placement, because what they're gonna do here is they're going to actually inject or they're going to actually insert some needle to actually check that muscles, that neuromuscular activity abnormalities. So after the procedure, as the nurse, what you're gonna do is to inspect the sites of the needle where they inserted that needle. Okay, and then after that, we want to make sure that the patient actually returns within 5 days, because we are going to have to do a blood drawn for the enzyme test. Enzyme that is actually has something to do with the muscles, right? Because again, we're checking for neuromuscular abnormalities, which is your AST, your CK, creatine kinase, and then your LD. And then you have your radiologic studies, which is your brain scan, cerebral angiography, your CT scan, computed tomography, your magnetic resonance imaging, and your myelography. Okay, so for brain scan, let's start with brain scan. What they're gonna do is a brain scan depicts the pattern of distribution of a radioactive isotope that has been injected intravenously. What are they trying to check? They're trying to check if there's like brain abscess or tumors, if there's any hemorrhage or hematomas inside the brain. Pre-procedure, our responsibility is to make sure that there's an informed consent. Please remember that this test is actually contraindicated during pregnancy. Potassium chloride is given several hours before the procedure, but during the procedure, what they're gonna do is they're going to give that isotope, inject that isotope to the patient, and then the patient is going to lie on a stretcher while the scanner is actually moving over the head. After that, post-procedure, responsibility of the nurse to encourage oral fluids to promote elimination of that isotope that we injected to the patient. Cerebral angiography is kind of like the same thing. What we're gonna do is we're gonna inject that contrast medium also, and then they're going to do that radiographs or pictures to see if there's anything that is actually in the brain, like tumors or abnormalities in the cerebral carotid. So pre-procedure responsibility of the nurse is to make sure that there's an informed consent, checking if the patient is allergic to shellfish or iodine because of the contrast media that we're actually going to inject to the patient, remove any metal from the head area, and then making sure that the patient actually knows that we're going to put the dye, we're going to inject the dye while we're actually taking those radiographs. The patient may feel flushed, warm, and nauseated, and report a salty taste when we're giving this contrast media. All right, post procedure for your cerebral angiography, you make sure that you are applying pressure to the puncture site and monitor for the bleeding. Bed rest may be ordered for a specified period. And then I did mention that we are actually monitoring the patient for allergy to the contrast media. So pre-procedure and post-procedure, we are monitoring for the patient if they have an allergic reaction to the contrast media. CT scan, pre-procedure, we just want to make sure that the patient may be NPO 4 to 8 hours before the scan. If we are actually using a contrast medium, they can prescribe medications and diabetic diet. What does it do? The patient is just laying down on a stretcher, and then they're going to go into that donut shaped frame that moves around the head. Post procedure, no special aftercare is needed. MRI. So pre-procedure, we just gotta make sure that there is no metal in the patient's body because the MRI actually contains those magnets. So those MRI magnet can cause metal to move in the body. No special aftercare is needed. And then in addition to these things, we also have some studies that actually are checking for like blood flow, especially those like carotid arteries, the ones that's supplying those blood flow to the brain, and spinal cord. So what they do is they're actually going to like do an ultrasound, like we call it Doppler flow. This one is using an ultrasound to actually see the blood flow in those arteries, in the carotid arteries. Pre-procedure for blood for Doppler, you make sure that there's a signed consent. Inform that the patient, inform patient that the test is actually painless, but not to smoke for 30 minutes before the test. And then the patient will actually be in a supine position while that ultrasound is actually going, up and down and side to side. No special aftercare is needed. Okay, drug therapy for neurologic disorders. We have antimicrobials, which is your antibiotic, especially if you have like infection that is actually caused by bacteria. Then we use antimicrobials or your antibiotic. Analgesics for pain, anti-inflammatory, obviously if there's like an inflammation that is involved. Corticosteroids is the same, it's an anti-inflammatory. Um, Anticonvulsants for seizures, right? This is an anti-seizures. Diuretics is to help with the cases or disorders, for example, that makes the patient actually retaining those CSF, for example. Chemotherapeutic agents, obviously, for like those cancers or tumors. Dopaminergics, anticholinergics, and your cholinergics. and then you have your antihistamines. Common surgeries for neurologic disorders, you have craniotomy, craniectomy, and cranioplasty. Craniotomy is a surgical opening of the skull. This one is done when we want to correct like tumors, um, taking out or evacuating those hematomas to relieve the pressures. They actually use this for correcting like defects. Craniectomy is excision of a segment of the skull. And then cranioplasty is a procedure to repair a skull defect. Okay, let's talk about intracranial pressure. Intracranial pressure is obviously the pressure inside the cranium or the brain. So the brain itself is enclosed into a skull. But the brain, remember, it has the brain tissue, it has the brain blood flow, and the CSF. And if there's an increase volume in one of those things, then there's going to be an increased pressure that's actually pushing against the skull. And that's what we call an increased intracranial pressure. The normal intracranial pressure, or ICP, is actually 0 to 15 millimeters Hg. So it's 0 to 15 millimeters Hg, virtually like nothing, right? Or very, very minimal. Okay. Um, the three components that's actually affecting your intracranial pressure is the brain, the blood, and the CSF. Okay, those three components, brain, blood, and CSF, those are the three components that's actually affecting the ICP. And what does it mean? It means, for example, maybe a patient just had an accident, right? Trauma, hit the head really bad, and now there's like increased bleeding to the brain, right? There's blood in the brain. So now think of it that the brain is actually inside that skull, and now there's an increased pressure, right? Because of the bleeding inside. Then it's going to create that increased intracranial pressure. And why don't we want that increase in ICP? Because if there's an increased ICP, the perfusion or the delivery of the blood and oxygen to the brain tissue actually decrease. Okay? So that's why we want to prevent, or we don't want that ICP to be increased. Okay? Um, there's also what we call a Monroe-Kelly hypothesis. The book actually talked about it in page 365 if you want to read through it. Monroe-Kelly hypothesis. This one describes the adaptations that must occur between the three components, which is your brain, blood, and CSF, for ICP to remain normal. One example is if the patient actually has a brain tumor, so there's now an increased pressure of the brain tissue itself. Monroe-Kelly hypothesis is telling us that the brain is actually going to adapt. What it's going to do is, because there's an increased pressure in the brain tissue, then it's going to adjust that blood and the CSF flow. What it's going to do is it's going to decrease those two components to make it equal, right? The goal is to not have the increased ICP, okay? All right, what are the signs and symptoms of increased ICP? If we're talking about ICP, the first and the biggest thing to remember is level of consciousness, okay? Level of consciousness is the most reliable indicator of mental status. because of its extreme sensitivity to oxygen levels in the cerebral blood. So if there's an increased ICP, then the first thing that you will see, or the biggest thing that you will see in the patient, is there's going to be a change in level of consciousness. What does it mean? Well, your patient that came into the ER, came to your care, that is actually alert and oriented and was talking, is now becoming very drowsy, or agitated, or maybe even unresponsive, right? There's a change in the level of consciousness. Another signs and symptoms that we will see in increased ICP, there will be a classic changes in the pupils, okay? There will be a classic changes in the pupils. There is what we call a dilated state, or a blown pupil is what we call it. The pupil will be dilated. We call it blown pupil. It will be dilated and is fixed. And if you shine a light there, it's going to be fixed and it's not going to react anymore. What's the cause of this? This change actually occurs because of the pressure in the cranial nerve, your third cranial nerve, your oculomotor nerve. And this one is actually a late sign of increased ICP. And I'm going to repeat it. Increased ICP, when you're looking for signs and symptoms in a patient, early stage, you are going to see change in level of consciousness. Okay? Change in level of consciousness. In the late stage, that is where you're going to see that change in the pupils, pupillary changes, or what we call a blown pupil, where the pupil is now fixed, dilated, and it's not reacting to light anymore. All right, another indicator of increased ICP is the altered motor function. And what does it mean? Like your hemiparesis, right? Your weakness on one side, your hemiplegia, paralysis on one side. You will see that. For example, the pressure is actually increased on the right side of the brain. Then you're going to see that that altered motor function is going to be manifesting on the left side of the brain. I mean, of the body. Okay, for those severe cases, you're going to see those abnormal posturing, what we call abnormal flexion, or your decorticate posturing, and your decerebrate. If you look at page 366, page 366, take a look at those two abnormal postures. Okay, the first one, the one on the top, is an abnormal flexion. Decorticate is what we call it. You're going to see that the arms is actually flexed, the hand is flexed, the arms is actually adducted, and the legs are actually internally rotated, and there's a plantar flex. Okay, when you see this kind of abnormal posture, this one actually indicates that the damage is actually above the midbrain, okay? Now, if you look at this next picture, this one is actually what we call decerebrate rigidity, another abnormal extension posturing. If you look, the arms are actually adducted and extended. The hands are actually pronated and flexed. There's a plantar flex. And then if you see this abnormal posture, this one actually indicates that the damage is actually in the midbrain and the upper pons, which is very serious, because remember, what is the function of your midbrain and your pons, right? Okay, another thing to remember for your increased ICP, there is what we call Cushing's triad. Cushing's triad. What is Cushing's triad? This is widening pulse pressure, bradycardia, and hypertension. Again, it's widening pulse pressure, bradycardia, and hypertension. What is widening pulse pressure? There's a widened difference between your systolic blood pressure and your diastolic blood pressure. Okay, that's what we call widening pulse pressure. Bradycardia, is the decreased heart rate, and then hypertension. That is what we call Cushing's triad, which is generally associated with increased ICP. Medical treatment for your increased ICP. Well, it really depends on what is the reason of the increased pressure. But first, what are we going to try as nurses? We're going to see if we can actually help the patient decrease the ICP with positioning, um, correcting some signs and symptoms. For example, if your patient is needing the fluid management, then you're going to make sure that you're addressing that. Drug therapy, there is what we call a mannitol, right? That medication mannitol that is helping to actually flush out all those fluid. You're gonna want to make sure that you're giving your patient oxygen, right? Because you want to preserve the oxygen delivery to the cerebral tissue. So you might want to give the patients oxygen. Positioning actually is making sure that you're raising the head of the bed maybe like around 30 degrees. Some patients we might need for them to actually have the mechanical ventilation. So we're going to put them on the vent to make sure we're actually saving that airway. If the ICP is actually caused or increased ICP is actually caused by um, increase of that CSF, then we might need to actually do the what we call ventriculostomy catheter. We'll talk about this when we talk about hydrocephalus. But point is, we're going to treat or do the medical treatment for increased ICP based on the reason of the increased ICP. All right. Some trivia questions. Stress triggers the sympathetic nervous system too. I'll give you some seconds to think about it. All right, correct answer is A. Increase the secretion of epinephrine. Rationale. Stress triggers the sympathetic nervous system to increase the secretion of epinephrine and norepinephrine. These neurotransmitters increase heart rate and constrict peripheral blood vessels, causing the blood pressure to rise. This reaction to stress is called the fight or flight response. Question number 2. Which of the following is not a normal aging change? Give you some seconds. All right, correct answer is C. The pupil of the eye is often larger and may respond to light more slowly. Rationale. Brain weight is reduced and the ventricles increase in size. An aging pigment called lipofuscin is deposited in nerve cells, along with amyloid, a type of protein. Increased plaques and tangled fibers are found in nerve tissue. The pupil of the eye is often smaller and may respond to light more slowly. And that concludes